Hi, everybody. My name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston, and I'm focused on stomach and esophageal cancers. Super happy to be here to talk about a very common topic, which is biomarkers in gastric and esophageal cancers. You can see the disclaimer up here. This is obviously brought to you by Hope for Stomach Cancer and the Esophageal Cancer Education Foundation. I'm going to take over and start sharing my slides so that we can get into this. If there is questions, please put them in the Q&A thing on Zoom, or raise your hand. I think I'll be able to see people with their hand raised, so we can call on you. I'll probably talk for like 25 minutes, 30 minutes, and then we'll get into some questions. All right. So it's all about biomarkers. I'm going to talk a little bit about the who, the what, and the why. Like why is this such an important topic? Talk a little bit about biomarkers in localized disease, where the stuff we use in stage 4 is starting to make its way to stage 3. And that should ultimately translate to better outcomes and more cures. That's certainly the hope. Bulk of our time we'll be talking about biomarkers in advanced disease. And then we'll talk a little bit about pros and cons of biomarker testing or use of targeted therapies in biomarker-negative patients. So this is a real big theme throughout the biomarker world. And it's really about trying to predict who is more likely to benefit or get a survival improvement from a given biomarker. Most patients' tumors will have some degree of some biomarker, and it's really about picking the people and finding the right balance. So I've tried to think of the ways to make this analogy with regards to biomarkers, and it's kind of like, if you're 5 foot tall, you probably can't dunk a basketball, but there are probably some 5 foot tall people who can. So the average 5 foot person is not going to be dunking. The average 7 foot person is definitely able to dunk, although there are still some 7 foot people who can't dunk. I don't know how, but they can't. Biomarkers is kind of the same way. Let's take PD-L1, for example. So a PD-L1 negative patient, like a 5 foot person, probably doesn't get a lot of bang for the buck from adding PD-1, but there are still PD-L1 negative patients who benefit. The other end of the spectrum is the person who has a PD-L1 expression on the tumor that's very high, like greater than 10. They're very likely to benefit, but there's still people who have greater than 10 that don't benefit. So this kind of spectrum is something we're going to talk about in multiple biomarkers. And I kind of have the first 5 slides that is presenting this in multiple ways. It's a little bit beating you over the head with it, but sometimes I think hearing it in multiple different ways, maybe one of them will click. So if you remember, and I do remember this growing up, these ads like, this is your brain on drugs. So this is you, this is you without biomarker testing. So people without any biomarker testing, generally they're going to do worse because they're not getting the potential advantage that comes with knowing the biomarker and using that information to guide therapy. So I equate this is a survival curve on the right, and basically it looks at the percent of people alive over time, and this is how most clinical trials are measured, is do you have more people alive on one arm than the other arm? If that's true, then that therapy has helped to improve survival. And so we know from several biomarkers in stomach and esophagus cancers that they do improve survival when you receive the appropriate biomarker-directed therapy. There's a couple that is the bare minimum, and why is biomarkers even important? Basically, before you go into battle or go into anything, buying a new truck, you basically want to go in with the power of knowledge. You want to know, like, has that truck been in a bunch of accidents? Did someone duct tape it together and then spray paint over it to keep it together? Like, that truck is probably not going to do as well as the one that's been maintained by the owner who's a mechanic and gets oil changes and air filters and everything. And that's kind of like biomarkers. We basically want to know about the tumor. And biomarkers come in two essential flavors. One is predictive, and this can be, of course, positive or negative. So these tell us if you're more or less likely to benefit from a therapy. So for example, HER2 expression is a predictive biomarker. The presence of HER2 tells us that you're more likely to respond than someone who doesn't have that biomarker to a HER2 therapy. Prognostic biomarkers, and a biomarker can be both predictive and prognostic. A prognostic biomarker tells us about the biology of the cancer itself. So some tumors are faster growing or more aggressive than others, and some are slower growing. And in general, someone with a slower growing tumor lives longer. And so microsatellite instability, or MSI-H, is both a predictive biomarker because it predicts response to immune checkpoint inhibitor, but also a prognostic biomarker. If you take everybody who's MSI-H and everybody who's not MSI-H, regardless of the treatment you get, the MSI-H patients live longer. So their survival is better. That just tells us about the biology. So this is an important theme in biomarkers. So it's relative expression, how much of the biomarker is there, and is the biomarker predictive or prognostic, or both? This is the bare minimum for biomarker testing. So HER2, every stage 4 patient at diagnosis should be tested for HER2. About somewhere between 15 to 20% of people are positive, and it's a predictive biomarker. It's associated with benefit from trastuzumab, Herceptin. PD-L1 is, again, all stage 4 patients should be tested at diagnosis. This one exists on a spectrum, and most people are positive. So it's probably more like 75 to 80% of people are positive for PD-L1. And this is associated with a predictive biomarker. So it predicts for benefit from immune therapy like pembrolizumab or nivolumab, or the brand names there. MMR and MSI testing is the least common biomarker. It's only like arguably 2 to 5% of stage 4 patients, and somewhere in the 10 to 20% of stage 2 and 3 patients. And this is prognostic and predictive. So these patients, it predicts for benefit from checkpoint inhibitors. It's also a favorable feature. You're just likely to do better regardless. So my dad builds furniture for a living, and helping him in the shop, I've heard this expression a million times, which is measure twice, cut once. It's kind of like biomarkers. You want to look, and you want to look thoroughly so you don't have to go back and change. Like if you start on some therapy and then you find out you have a different biomarker that might guide you to change, ideally you'd have everything up front. So a good biomarker should tell you about the tumor. It should tell you about the chance of a drug working, and it might tell you about survival. It also should be reliably testable. So some biomarkers are actually not so straightforward to test for, and some have a very reproducible test where if you get your test in Idaho or you get your test in Boston, the chances of the results being the same are very high. And something like MSI-H is a very good biomarker. It almost never changes over time. It almost never changes between areas of the tumor, and the results are very reproducible. If I would believe your MSI testing from an outside place 99% of the time. So biomarkers, kind of like a menu. If you go to a local small diner on the side of the road, they've probably got like 2 options, like, do you want the eggs or the pancakes? And currently, unfortunately, that's a little bit like where we are in gastric cancer. We have these standard biomarkers, like I just told you, MMR testing or MSI, HER2, or PD-L1. That's basically our menu. There's a bunch of other stuff on the right that we're interested in, but technically it doesn't have a real big role in standard of care therapy. This is where we want to be. I don't know how many people have cheesecake factories near them, but the menu is like, a dictionary, and you spend like half the dinner just trying to decide what you want to order. But this is where we want to be. This is where, like, our friends in lung cancer has like 10, 12 targets, that are approved. And so they test a lot, and most patients will have some option. In gastric and esophageal, we're not there, but that's what, people like myself and other people who are doing research in this area are trying to improve upon. So what's probably the ones that are closest to the clinic are listed here. So includes the standard mismatch repair, HER2, and PD-L1. Claudin 18.2 is very close to the clinic. This drug's approved in Japan, and it's expected to be approved in the US probably in November. So we're all eagerly waiting. And then we'll have to test everybody for Claudin. Some centers are already testing. FGFR2b is another biomarker that is in phase 3 trials, which are mostly done. And so we're waiting for the results. And if they're positive, then we're going to need to test for FGFR2b. And for research and clinical trials, these things on the right are becoming more and more relevant. So this is not too far in the distant future. Claudin is probably months, FGFR2b maybe a little bit longer, but this is coming. So there's definitely hope for more biomarkers. So this whole theme of being biomarker negative is going to get less and less common in stomach and esophagus cancers, which is great. So I want to get a little bit into the weeds here, and hopefully I can explain this, because this is a lot of what we talk about at like conferences with each other, but probably don't do a great job of explaining to patients. So on the left at the top is a tumor. And this is sort of the way we used to think about tumors. Like you're either positive or negative. If you cut this tumor in half, like you're cutting a watermelon in half or an orange in half, I have that knife and the line going through the tumor, and then you put it on a slide and looked at it under a microscope, a tumor that has the biomarker that's uniformly distributed, so basically like all the cells have the biomarker, will look like the image on the bottom. The brown being the tumor cells with the target. And so basically all the tumor cells have the target. And this is great. A perfect biomarker would look like that. MSI looks a lot like that. So if it's MSI high, almost all the tumor cells are going to be MSI high. And that's probably why things like immunotherapy work so well for those patients. The problem is, in the real world, most people live on the right side of this picture. If you cut this tumor, which is more like a real tumor, which has a whole bunch of different clones, so tumor cells that are slightly different, and you cut it in half, you're going to get something that looks more like the bottom, which is the reality of most biomarkers. So this tumor down here has some brown, which is the target that you're going to give the drug, but it also has some red and green, which are different populations that are not going to be killed by the targeted therapy. The other analogy that I've come to like a little bit is like an old school gumball machine. So, you've got like red and blue and yellow gumballs. And if you give a targeted therapy that wipes out all the yellow gumballs, you've still got the blue and the red that you didn't get rid of. And so they're eventually going to grow out and become progression or recurrence of a cancer. So this is a real problem for us, is how do you deal? The left side of this picture is easy, and those patients do great. And the times that you hear someone who's like been on trastuzumab for like 5 years and they have no evidence of cancer, they probably looked a lot more like the left side of this picture. And if you hear about someone who got trastuzumab and 6 months later their tumor was growing, they probably look a lot more like the right side. The problem is we don't have great tools to tell you when you're in the clinic, like, do you look more like the right or the left? And that's something we're all working on. To drive this home a little bit more, this is an actual tumor. So this is from our own research. And what you're looking at in the bottom middle is a zoomed out version. So it's basically the same as the bottom right picture. And each color represents a different target. So pink is HER2. And you see that there are tumor cells which are marked in orange here, like in the top left. There are tumor cells that are HER2 positive in pink, and there are tumor cells that have no HER2, but they have a different target, in this case TROP2, which is a new target. And so this actually is what the tumors look like. It's the cartoon on the bottom right is a pretty reasonable approximation of what it actually looks like under the microscope. This is an actual patient's cancer. And if the white box on the bottom is basically just the zoomed in area that you're looking at in the small boxes around. So this is the reality for all of our patients, well, most of our patients. So one of the topics of this webinar is like, how common is it? I mean, what do you do for biomarker negative patients? And I think there's actually not as common as you might think it might be. So I'm going to go through the main biomarkers and just tell you a little bit about them. And people ask like, what do you do for my biomarker negative? Well, a lot of people are actually not biomarker negative. So let's start with PD-L1. Again, PD-L1 is the predictive biomarker for immune therapy benefit. And if you look at some of the big clinical trials, which I'm just highlighting a couple here, you see that about 80% of people are PD-L1 positive. So only about 15 or 20% of people are negative. So the negative people, we'll talk a little bit about whether they really benefit from getting checkpoint inhibitor. But most people are positive, and you can see that in these clinical trials. So you still need to test, even though most people are positive, because the degree of positivity also matters, and I'll show you a little bit about that too. Claudin 18.2 is coming in the very near future, and so we're have to talk about that one too. This is from a recent paper by a colleague, Kohei Shitara. So you can see at the top, these were two big phase 3 trials, Spotlight and Glow. You've probably heard about them mentioned in support groups and things like that. But if you look at the overall population, you see the number of patients is that top row, 1,730, so 1,730 patients were positive and 2,777 were negative in the combined analysis. And then the columns in the middle and right are by individual trial. So if you look, this biomarker, Claudin 18.2, at the cut point that they used for the clinical trial, 38% of all the samples tested were positive. And that means about 62% of the patients were negative. So it's, about a 40% chance of being positive in this, for this biomarker. It's interesting if you look a little bit by region of the world, there is a little bit of variability. So if you're in South America, you're a little bit less likely to be Claudin positive than if you're in Europe and the Middle East. And you see that 30% versus 44%. These are relatively small numbers for some of these geographic locations, but it is interesting and makes us wonder if maybe there's something about the risk factors for a stomach cancer in South America that are different than the risk factors in Europe and the Middle East. And that might drive why some cancers have Claudin and some don't. We don't know the answer to that. It turns out that a lot of Claudin positive tumors are also low for PD-L1. So again, those PD-L1 negative patients, that 15-20% that I just showed you on the last slide, a good chunk of them are going to be Claudin positive. So there's becoming less and less actually biomarker negative patients. So this is sort of the main biomarkers, and I included the emerging ones again. And you see the left column is the target or the biomarker, and the right column is how common is it. And so you see that if you take any given patient and you were to add up all these, you've got a pretty good chance of having one of them. And if you're lung cancer, I think the estimates are somewhere in the like 60 to 80% of people will have some target. We're not quite that high for stomach cancer unless you include PD-L1 at a cutoff of 1, but we're getting there. So a lot of people have some biomarker, and that's great. So I want to test question for people who've been paying attention. So we're talking about biomarkers. You've got 3 patients here, 1 person bottom left, 1 person in the middle, 1 person on the right. These are different tumors. You got the drug target in green and the drug in purple. So like ask yourself, kind of like the 5-foot versus the 7-footer, like who's more likely to dunk? Who's more likely to benefit from a targeted drug? The person who has a tiny amount of the target, almost none, the person who has a moderate, or the person who has a lot of the target. And that is exactly what PD-L1 is like in gastric and esophageal cancers. It's a spectrum. and it's a spectrum of expression, and it's also a spectrum of benefit to a certain degree. So I'm going to walk you through a clinical example in the last 10 minutes of this talk, and then we'll have time for plenty of questions. So let's say a patient comes into my clinic, young guy, new stage 4, otherwise healthy, probably a story that many people who are listening can relate to. Gets the standard of care testing, is negative for PD-L1. So in that 20% of people who are negative for PD-L1 is negative for HER2. So again, about 80% of people are negative for HER2 and is negative for MSI-H. So about 95% of people are negative for MSI-H in stage 4. So he asks a very good question, what are we going to do? I don't have any of these targets. So this is what in Europe they say to do. And actually the ASCO guidelines are very, very similar. And then we're going to talk a little bit about some of the reasoning behind these guidelines. So if you follow this flow chart from the top, this is the patient, comes into the clinic, newly diagnosed stage 4. If they're HER2 negative, like our patient, the next question you ask is, are they PD-L1 positive or negative? And do they have MSI-H? And so we told you the patient is negative for MSI-H. So the far, I don't know if you can see my arrow, but the far right is off the table because they're MSI negative. And they're PD-L1 negative. So this far left arm goes away. They're in the middle. They're HER2 negative. They're PD-L1 negative. So everybody gets platinum and fluoropyrimidine chemotherapy in this situation. So that's basically like FOLFOX. That's the backbone for basically all of our patients. This patient who's HER2 negative and PD-L1 negative, in Europe, they make a question mark of, should we think about adding FLOT? Since we don't have a targeted therapy like HER2 or immunotherapy, should we think about escalating or intensifying the chemotherapy? And honestly, I've done this a few times for my own patients, particularly young people who you really need a response. Because FLOT does have a little bit higher response rate. It also comes at definitely a higher side effect rate. That's why it's listed as a discussion and it's not strongly recommended. And then in Europe, and I know this question is beyond the scope of today, but it comes up a lot, which is, do you consider surgery ever in stage 4? And in the European guidelines, they leave it as essentially the door is open to it, but they do not recommend it. All right, so let's go back and use the same analogy. So you've got the patient in front of you, 56-year-old guy who's this PD-L1 negative person down here in the bottom, who's unlikely to, or maybe I should say, less likely to benefit from immunotherapy. Someone who's very positive for PD-L1, so like those 3 tumor examples I showed you a couple slides ago, this person over here, it would be a no-brainer. You would definitely add PD-1 like pembrolizumab or nivolumab or tislelizumab to this patient. The greater than 5 patient has a pretty good chance of benefiting, so most of us would definitely add it for this patient too. Here's the negative patient where this is the gray zone, and this is where there's a lot of variability around the country. There's a lot of variability at big institutions. Take Dana-Farber, MGH, MD Anderson, Memorial Sloan Kettering, UCSF, etc. There's variability even at these big places. So where does that variability come from? Like, we're all looking at the same data, so how can we be interpreting it kind of differently? And this is a little more philosophical, but it is important. So where is the data about PD-1 in PD-L1 negative patients? So this is our same patient. Over here on the right is data from Dr. Janjigian's trial, Checkmate 649. This is a paper in JCO not that long ago. And the reason that it calls into question is if you take this bottom group, so the greater than 10, so this patient over here, this 7-footer who can easily dunk or easily going to benefit from PD-1, you see that the difference between the survival is 10.9 months versus 15 months. So that's a meaningful benefit. That's about a little over 4 months of extra life because of immune therapy. So it's kind of a no-brainer for this patient. And that's why this bar over here is way over to the side of in favor. So you're like tipping the scale way over in favor of the side of adding immune therapy. The greater than 5 patient also, gets close to 3 months of extra life by adding immune therapy. It's this person down here where the difference between 12.5 months and 13.1 months is like a couple weeks. And that's why this bar here is very close to 1, where there's really no difference between these two patients. So the question is, why do you add immune therapy to someone who is less likely to benefit, especially when there's a risk of toxicity? And this is where the variability comes from. There are some people who will say, look, we don't know how you're going to respond. It's not a perfect biomarker. There's some 5-footers who play in the NBA and can dunk. So you might be a PD-L1 negative patient who's going to benefit from immunotherapy. And maybe you'll wind up one of those kind of home run patients. And then there's other oncologists who will say, well, if you look at all the data combined, on average, most people who are 5 feet can't dunk, and most people who have a PD-L1 negative tumor can't benefit or don't get a benefit from immunotherapy. And so that is where the variability comes from around PD-L1, and hopefully that makes some sense. But if you said, okay, we're going to do it, we're going to give you immunotherapy in PD-L1 negative situation, so your biomarker is negative, do we hurt those people? And the question seems to be, the answer seems to be not clear. It doesn't look like we hurt them on average. The data does not suggest that. So here is taking everyone together. This is not just PD-L1 negative, and this is from a different trial. This is from KEYNOTE-859, which is another big study. And essentially, these are questions that patients answered during the clinical trial about their symptoms. And so the improvement is the bars going down below the line, and the worsening is things go up. And the sort of purplish colors is the people on no immune therapy, and the green color is people who got chemo plus immune therapy. And so you can see that largely these things basically track identically. So it's not like adding immune therapy made people have worse change in taste. It's about the same between the chemo and the chemo immune therapy. That's because most of the taste changes come from the chemo, and both people get chemo. If you look at the hair loss and the body image and dry mouth, these error bars overlap. So these, although the bar heights look a little different, they're actually not statistically different. So these groups are interpreted to be the same. And both groups get improvement. And arguably, there's a couple things like reflux symptoms that look like the immunotherapy group maybe has a statistical difference in favor of them. So it doesn't look like we're hurting people in general in terms of quality of life with immunotherapy. It has to be balanced against side effects. So if you're going to give someone who's PD-L1 negative or total biomarker negative immune therapy, you have to have a conversation with them about obviously the chance of benefit. That's what we were talking about before, but also the chance of side effects. So this is a table from a clinical trial. You probably are not looking at this level of detail for most of your own treatments, but this is the data that when we tell you like, oh yeah, you're going to have some fatigue, you're going to have some neuropathy, you're going to have some blood counts, that it comes from tables like this. And so pembrolizumab plus chemotherapy is over here. This is again KEYNOTE-859 trial, so a lot of patients. And then placebo plus chemo, so chemo only. And you look at the frequency, so the percent of people who got a side effect. And you can see that overall it's pretty similar. So let's take, for example, peripheral neuropathy. So chance of any peripheral neuropathy is, somewhere in the 18 to 20%. And it's basically the same 18% here in people getting immunotherapy as over here getting chemotherapy with placebo. And you just go through all of the side effects and you see that basically it's pretty similar between these two groups. When you look at the main side effects of immune therapies, and those of you who've been on or are on immune therapies, maybe you've had some of these, there's clearly a difference. So if you don't get immunotherapy, you generally don't get immunotherapy side effects. And so you see, for example, hypothyroidism. About 15% of people got hypothyroidism on immunotherapy, and without immunotherapy, only 4%. So much more likely to get hypothyroidism. Thankfully, hypothyroidism is not generally a clinical problem. Most people don't really feel it. We just put them on a thyroid hormone and we correct the number, but they usually never knew that it was low clinically. Some of these other things, they're rare, but they still need to be talked about because grade 5 is dead, by the way. So that means this one person died of pneumonitis. And you see that basically that doesn't happen without immunotherapy. Grade 4 is you're sick enough to be in the hospital. And so again, these things are more common with immunotherapy. So immune therapies are great. Definitely a believer, but there are still people that have serious and sometimes life-threatening side effects from immune therapies. You see hepatitis, these are inflammation in the liver. You see severe skin reactions, 2% is rare, but 2% severe skin reaction is like your skin kind of falling off, and that's no fun. And so there is a difference. And so when you got this person in here over on the right, who's a real person in front of you, you got to say, we're going to do this. You might be one of those people who benefits. That's why we're going to do it, because we know there's some of those people out there, but you also might be one of these people that has a side effect. And so ultimately it's down to the patient to get all the information and then make a decision. And the same is true for clinical trials and new drugs. Ultimately, you just want to get all the information you can, and then it's a little bit of a leap of faith at the end of the day, but our job is to give you all the information. So a couple common questions before we open it up for questions. Do biomarkers change? And the answer is yes. So if you take the tumor on the left, which is someone who starts with a lot of the target, and you give them a targeted therapy, I'm going to use HER2 here because it's an example we have a lot of data for. You're probably going to be pretty good at killing the HER2 positive cells. So after treatment, if the disease starts growing, if you did a biopsy, there's a reasonable chance that the tumor is now going to look like the picture on the right. This is the same idea as the gumballs. If the tumor on the left is a gumball machine that is 80% blue gumballs and 20% yellow gumballs, the tumor on the right is now almost all yellow and no blue because you killed off the blue, but what's left behind was the yellow to grow out. And so this is a problem for targeted therapies mostly. This is true of other targets like MET and EGFR. We don't know if this is true for Claudin. We just don't have enough data. Since Claudin is not yet approved in the US for routine practice, we don't have people who've been on Claudin and then their tumor responded and then grew to see if they're still Claudin positive. We don't know. That's a very interesting question and area that we all want to get data for. The other question that happens a lot is, do biomarkers depend on the site of sample? So I think of this analogy on the left, which is if you took a bunch of blindfolded people and asked them to touch various parts of an elephant and say, what is this? If you touch the tail, you might say, hey, this is a rope. If you touch the leg, it's a tree. If you touch the tusk, it's a spear. And nobody gets the whole picture. So no one says the correct answer, which is it's an elephant. And this is very similar to the problem of a lot of biomarkers. So on the right, if you put your biopsy needle through the tumor at the top and you miss an area or you hit an area that doesn't have the target, then all you can do is work with the data you have and you're going to say, hey, this tumor is HER2 negative. And the bottom might be a biopsy from the same tumor in a different spot. And if you hit it there, you might hit some regions of HER2 and you're going to say it's HER2 positive. This is a big problem for our field. It's also a problem for biomarkers. So for a really, really good biomarker like MSI, like I mentioned, every single cell in that example on the right would have the biomarker. So if you biopsied the top half, the bottom half, from 8 to 4, whatever, you're going to hit cells with the biomarker. So you're going to get the same answer. The person's going to be MSI high. And that's why MSI-H is probably one of our best biomarkers, because it's very uniform. HER2, Claudin maybe to a certain degree. Claudin may be a little bit closer to MSI, where most of the cells that are positive in positive tumors are positive. HER2, we know, is very heterogeneous. I showed you like TROP2 in that picture from an actual patient. And so this is a big problem. And this is why when like we get patients to come see us, and if they've had a biopsy of their liver and if they've had a biopsy of their primary tumor, oftentimes we'll try to get biomarker testing maybe from all of those spots, or if they were on chemo for a year and then their tumor started growing, we would think about re-biopsying it, because we know that this problem and this problem exist. And so people can go from positive to negative, but can also go from negative to positive, because you might have just missed the initial positive. So we're getting better. I want to leave the end of the sort of lecture part of it with some hope. And so the current biomarker negative is this group of people over here on the left. And they're only biomarker negative because we just aren't good enough at having all the drugs and targets. Everybody's tumor has something. It's not normal. And chances are, if you had enough targets to look at, everybody would have some biomarker. And I'm just highlighting a couple here that are out in clinical trials. So PTK7 is a drug target. It's basically a marker, kind of like Claudin 18 for tumor cells. DKK1 is an immunotherapy target. TROP2, there's a big phase 3 trial. CDH6 is a CAR T target. TIGIT is a target of another immune type of therapy drug. EGFR and MET are targets that are on the tumor cells in a good chunk of patients. And so the hope is that if I give this talk, you know, a year from now, if Aki invites me back, if I did a decent job, then we'll actually have a lot more to talk about. And those people, like some of you who might think you're biomarker negative, will actually have answers for and more drugs for. So I will stop there. This is me. It's my email. You can email me for questions, and I think it's time for Q&A. And did I miss any of the Q&As?
No, there's nothing in there right now, but we do have the pre-submitted questions. Do you have those handy?
I do have them somewhere.
I can read them out loud to you if you'd like.
Maybe that's good, because I have like 30 emails in the last 30 minutes.
No, so what information should I look for to determine biomarkers or lack thereof?
Yeah. So you look for the biopsy pathology report is the most common place to look for biomarker results. Sometimes in the very beginning, the pathology initial results come back to say like it's cancer, but they haven't completed the biomarker testing. So you might even have to look back, or your oncologist might have to look back, or they might have even sent out for some biomarker testing. The other area that some biomarkers can detect, be picked up, is in the blood. So things that are proteins like HER2 and PD-L1, we can't detect in the blood yet. But things like MSI-H that are a mutation, we actually can detect in the blood. And that's why a lot of us will use blood in addition to tissue, because blood, one, it's easy. It often comes back faster. The results can come back in like 7 days. And it adds on top of tissue for some patients. So those are the main places to look. Obviously, you want to look at the closest thing in time as well. So let's say someone had a stage 2 cancer and they got a surgery, and then 5 years later, their cancer came back. We generally don't want to rely on information from the surgery 5 years ago, because, again, things may have changed. And so we would like to test the most recent biopsy. Sometimes we will test both, like I mentioned, because we want to make sure that we've given the patients the maximum chances to have a biomarker and have a matched therapy. All right, I see a few things coming in the chat. When a patient is NED, no evidence of disease, what should you do? Well, first of all, it's a great place to be. Very few of our patients get there. If you look at stage 4 patients, somewhere between 10 and 15% of people will, depending on the target, will have a complete response where their cancer is no longer visible. We will generally continue to treat those people for at least a good period of time to make sure that it's real and we believe it over time. It's very different if you're no evidence of disease after like a surgery for cure. Those patients we don't generally give any therapy. We monitor them, for 5 years, and then at 5 years we call them cured. And there's a lot of other things that can be done during that period of time, but the standard is, scans and checkups. Some people will use things like minimal residual disease tests from the blood, like Signatera or Guardant, or other companies are getting into this too. Please discuss outcomes people living with stage 4 who are being treated with immunotherapy without requisite biomarkers. So I assume that means PD-L1 negative, because that's the typical biomarker. As I showed you in the slides from the clinical trial, on average, the outcomes were really no different between chemo and chemo plus immune therapy in people who are PD-L1 negative. And that is the main reason why some people don't give immunotherapy to PD-L1 negative patients, because it's unclear that they get any additional survival benefit on average. That's averages. Again, any given patient, just like you could have a 5-footer who can dunk, there may be PD-L1 negative patients who have outstanding responses to chemo plus immunotherapy. It's very hard to tease apart because we never know if they would have just done great with chemo, because there's people who do wonderful with chemo as well, or if the immunotherapy really helped them. And this is sort of a area where we'll probably never have really good data. We sort of have to just work with the numbers we have. The FDA may ultimately step in and take immunotherapy away from PD-L1 negative patients, because there is, across multiple phase 3 trials, limited differences in the outcomes of those patients with immunotherapy. And I think that's a question that we're all waiting to see, and that would take the decision sort of out of all of our hands, because the insurances would not cover it at that point. Aki asked the question, number 7. So again, I think I just answered that one a little bit, but if you're PD-L1 negative stage 4, nivolumab definitely can be considered. In the current world, we can give immunotherapy to everybody. And that's nice because it allows the treatment team, you and your oncologist and your nurse practitioner and your nurse, to talk about it as a team and decide, do you, even though the averages are not very different, do you take the chance of being one of those people who does really well with immunotherapy? And I think a lot of people will choose yes, and that's why a lot of PD-L1 negative patients currently get immunotherapy. But again, this is exactly the question that the government is going to be debating very, very soon. Someone asked me what my email was. Let me put it in the chat. All right. Oh, I didn't put it to everybody, did I? So maybe I'll ask Aki to circulate it around or something. Do you think there's probability of HER2 changing with diffuse gastric cancer? Diffuse gastric cancer, for those that don't know, is about 30% of all gastric cancers. And this is a classification based on what it looks like under the microscope. So diffuse tumors, like, they don't make a ball of cancer cells that's easy to see. They actually make a spider web of tentacles that infiltrate into areas. And so it can be a very hard diagnosis to make. And unfortunately, there's a lot of people who come in with a story of They had 3 endoscopies and negative biopsies, and then the 4th one showed cancer. Those are almost always people with diffuse gastric cancer. And it sucks. It's a really tough entity, and it's frustrating for patients and frustrating for us too. Diffuse gastric cancers are less likely to be HER2 positive, but not impossible to be HER2 positive. So if you take a diffuse gastric cancer that is HER2 positive and you give it trastuzumab, a HER2 therapy, then yes, HER2 can definitely change with the presence of therapy. Because there is some regional variation, like I said, if you biopsy an area with the target versus an area without, it's a big problem for diffuse gastric cancer because there's not a lot of tumor cells in the biopsy. If you have more tumor cells, you're more likely to pick up a target. And so these are some of the main issues with diffuse gastric is sometimes they also fail biomarker testing because there's not enough tumor cells to do the testing. And that's a problem. I'm going to please share the name of the TROP2 phase 3 trial. I believe this is a big Merck study. I forget the name of it, Tropion or something along those lines. I see another question. I'm going to go to very interested in the comment you made about biomarkers changing, HER2 positive, negative. Would it ever go the other way? Negative to positive. So yes, this is a little less common, but certainly happens. So let's say you had a small biopsy of like your peritoneum and it was HER2 negative. And then a year later, you developed a spot in the liver and they biopsied the liver. And because liver tumors tend to have a little bit more groups of tumor cells, there is a chance that that biopsy could be evaluated and called HER2 positive. And I've had a few of those cases. It's relatively uncommon, but it's again, it has to do with the spatial heterogeneity. So differences between one site of disease and another, or differences between one region of a tumor and another region. The problem is, in a perfect world, if you could remove the metastasis like surgically, then you could actually look at the entire thing. And then you'd be able to tell if there are regions that are HER2 positive and HER2 negative. Problem is, most of our work is based on small biopsy samples. And that's just because, you know, one, it's just not safe to go in and cut everything out, and it's a big deal. That's why we're always working on blood too. So there are patients who the tissue test is negative and the blood is positive for HER2, for example. This is true of other targets too. And the reason we think that happens is that if you think about let's say you have a spot in the liver and you have a spot in the lung and you have a spot in the stomach and you have a lymph node. All of those areas have tumor cells, but you only biopsy the liver. So all you can look at under the microscope is the liver. When you draw a blood test, you presume that pieces of cancer cells from all of those other areas, so pieces of cancer cells from the liver are shed into the blood, from the lung, from the lymph node, from the stomach, they all enter the blood. So if you draw a blood test, you're getting a more representative sample because it reflects a liquid biopsy of all of the tumor in the body. And so I've had plenty of patients, it's not very common, but it's definitely, you know, it's a well-described thing that HER2 is negative on the biopsy that we had, but positive from the blood. This is a little bit of a difficult situation because by the current language for HER2 positive, it's defined based on tissue. So technically, in the current definition, someone who is negative by tissue but positive by blood is still considered negative. In my own practice, and I think in many people's practices who do this a lot, that patient, we would still try to give them HER2 targeted therapy in some way or another. It often can be quite tricky because insurances consider that person negative. And so looking at clinical trials, you know, we harass the companies, we do all the normal stuff we try to do to make it happen, but it can be quite frustrating for patients and for you know, providers. Someone asked about PARP, work the same way for germline BRCA. Would it turn off BRCA? So it's a very nuanced question. So Most of what we've been talking about today is based on the tumor. So we're assessing the tumor. More and more, and especially for people who are young, we also want to assess the normal DNA. So the normal DNA is like your normal white blood cells. So usually this is done by a blood test or a cheek swab, your normal, lining cells of your cheek. And the question that we're asking there is there a reason you got this cancer? Like, do you have a gene that you were born with that put you at an increased risk of stomach cancer? There are some that are very well described, like CDH1 and Lynch syndrome and BRCA1, BRCA2. These are mutations that, a small proportion of people are born with. And particularly if you had someone in your family who was like 40 and they got stomach cancer, like you should probably get yourself tested. That is a little bit different. So in those situations, of course, your normal cells have the mutation because you're born with it, but your tumor cells originated as normal cells. And so they also have this mutation. And so some mutations like BRCA can be sensitive to PARP inhibitors. And so I've had a few of these cases. All of us who take care of a lot of this disease have had a few BRCA positive or BRCA mutant gastric cancers. And we don't have, because it's rare, we don't have a lot of data. But yes, BRCA mutant gastric cancers can respond to PARP inhibitors. We used to have some clinical trials that were doing this. It's a little less common now. But again, if I had someone who had a germline BRCA mutation and a gastric cancer, I would start with the normal stuff because that's generally what we have the best evidence for. But for sure, that person is going to be getting PARP at some point if we can get it, or they're going to go on a clinical trial. So that very specific question, the answer is yes. Right. How do tumor mutations, for example, on KRAS report fit into this targeted category? So the answer is KRAS and Tempus and Guardant and Foundation Medicine and all these companies basically do mostly the same thing. What they do is they take your biopsy and depending on the company, they either will test it for proteins. So like PD-L1 and HER2 and Claudin, those are protein tests. And then they will take the tumor, the biopsy, and they will extract the DNA out of the tumor cells. And then they will sequence the DNA to look for additional mutations. And so they are essentially performing the exact same function as what some people's hospitals do already. But generally, they do it at a bigger scale. So for example, I told you the bare minimum for biomarkers is HER2, PD-L1, and MSI, and very soon it will be Claudin on that list. Your hospital might do those 4 things, but they might not do the sequencing part that KRAS and Tempus do. And KRAS and Tempus look, and Guardant and Foundation One look for like, somewhere in the order of like 300 to 600 additional genes. And so these are the really rare ones. So for example, EGFR or MET, those would not be covered by your hospital's standard tests, most likely, unless they're doing that. But things like those tests that you mentioned, they would. So they would call a mutation or an amplification in HER2 or KRAS or MET. And there's no drugs approved for that specific target, but it's great ammunition to have in your back pocket for future. So like we have a clinical trial that targets MET and a clinical trial that targets EGFR and so does Memorial Sloan Kettering and so do a lot of other big centers. And so we like to know that information for our patients. Not that we're going to change anything right away, but if something happens and the tumor starts growing, you kind of want to be prepared for plan B and plan C. And, like that G.I. Joe picture, whatever they say, knowledge is power. Someone didn't UCSD have a phase 1 clinical trial for Claudin 18 back in May of 2021? So I don't know the specific answer to that question, but many institutions had phase 1 trials. We had phase 1 trials of Claudin in dating back to like 2017, 2018. And there's a lot of different strategies to attack claudin. There's zolbetuximab, which is going to be the approved drug and is approved in Japan, but there's CAR T against claudin, there's antibody drug conjugates against claudin, there's bispecific antibodies against claudin, all of these, there's BiTE, T-cell engagers against claudin. It's a hot target, and so everybody's coming at it with different strategies. Zolbetuximab happens to be the farthest ahead. That's why, they have approval in Japan and expected in the US. But these other strategies may also be very good drugs. And there's a big phase 3 trial of an AstraZeneca drug called AZD0901, which is a claudin antibody drug conjugate being compared against standard chemo to see if it's better. And so there's a lot of enthusiasm for claudin for sure. The most recent question I see, can PD-L1 be tested via blood? So the short answer is no. All of our protein biomarkers, so Claudin 18.2 is a protein biomarker. HER2 is generally considered a protein biomarker, although there's an exception that HER2 amplification can be picked up in the blood. PD-L1 is a protein on tumor cells and local immune cells, and there are no tests in routine practice that pick up PD-L1 from the blood. So you need a biopsy to test for PD-L1. Suggestions on how to respond to immunotherapy when they're denying it. So that's, in my experience, a very unusual situation because the current FDA label in the United States for nivolumab and pembrolizumab is independent of PD-L1 status. That means that anybody with a stage 4 gastric or esophageal or GE junction cancer can get access to immunotherapy. HER2 positive patients, obviously we give them HER2 therapies, often in combination with immunotherapy, but I don't think I've ever had a patient, because the current FDA label is for all PD-L1 groups, including negative patients. So we've definitely have plenty of patients who are negative who have gotten immunotherapy because the FDA has approved it. So I don't know the nuances of that question or that case, but it should be doable. Obviously, if it's the approval is in the first line, so that means in combination with the first chemotherapy you get for advanced disease. Unfortunately, immunotherapy is not available for people with later lines of therapy. So if you got FOLFOX, and then you got Taxol and ramucirumab in the second line, and now you are in a situation where you need a new treatment, immunotherapy is not approved for that situation. So that, I don't know the nuances of the question, but in the first line, it should be available. If Garden shows nothing before first chemo, would you bother to retest it a year or two later? So great question. I would say in my own practice, I periodically will do that, but mostly for research and curiosity. Ideally, you have something in the beginning that you can compare to, so you can tell if it's, increasing or decreasing. There are plenty of patients who their tumor cells don't shed a lot of DNA into the blood, and so their initial test is negative. If in the future they have much more cancer than they have in the beginning, then there's a chance the test can go from positive to negative. I mean, from negative to positive. So if someone in that question that you wrote in, if there was a scan that suggested increasing tumor, that would be a very reasonable time to repeat the blood, because you're more likely to pick something up when there's more tumor cells. Because if there's more tumor cells, there's more stuff getting shed into the blood, and therefore you're more likely to pick it up. So we are at time. It's 2:59 and I have a 3 o'clock meeting. So I'm going to have to call it for the webinar. But this was awesome. Hopefully it was helpful. I know it's recorded, so I don't know what you can do with that. Send it around to friends. I have no idea. But look forward to the next one, and have a good long weekend. And I'm sure I'll see many of you on support groups, etc.
Thank you, Dr. Klepper.
Yep, no problem. Have a good weekend.